Good morning. Today in our last minute revision series for NEET PG, we will discuss about 25 onliners from Neurology. So crossed hemiplegia or crossed hemianesthesia syndromes mean the involvement is in the brainstem. Paraparesis or quadriparesis, it may mean there is a problem with either the spinal cord or it is a polyradiculoneuropathy. Example for polyradiculoneuropathy is GBS, that is involvement of nerve root as well as nerve. If there is involuntary movement, think of basal ganglia. Now, we localize basal ganglia. Chorea is a problem with the caudate nucleus. Athetosis is a problem with the globus pallidus. Wing beating tremors, which occurs in Wilson's, it's a problem with the lentiform nucleus. Hemibalismus is a problem with the subthalamic nucleus. Parkinsonism is a deficiency of dopamine in the substantia nigra pars compacta. If there is a pure motor weakness, that is without any sensory involvement, think of neuromuscular junction, muscle, anterior hornsel of the spinal cord, or the upper motor neuron. That is called as motor neuron disease. It could be lower motor neuron disease or upper motor neuron disease. There is pure motor weakness. Now, about the cerebrum. Broca's area is present in the inferior frontal gyrus. It is area number 44. Problem with this Broca's area causes motor aphasia or non-fluent aphasia. Wernicke's aphasia is area 22, which is present in the superior temporal gyrus. Stroke here or a problem here will cause fluent aphasia or sensory aphasia. It's a problem with the comprehension, whereas Broca's aphasia is a problem with word output or fluency. So in stroke, we have ischemic stroke and hemorrhagic stroke. Ischemic stroke presenting less than 4.5 hours, that is the window period, we have to prefer alteplase thrombolysis. In some cases we don't do, but we prefer alteplase thrombolysis. 4.5 hours to 24 hours time window, we cannot do thrombolysis, but we do mechanical thrombectomy. CT brain is the best immediate step in stroke imaging because it is time saving, but MRI is the best imaging overall for stroke. In subarachnoid hemorrhage, we have two types, aneurysmal SAH and traumatic SAH. Aneurysmal SAH commonly occurs due to berry-aneurysm. When it ruptures, there will be SAH. This berry-aneurysm or aneurysm is common in the posterior communicating artery. It will be close to the third nerve. And berry-aneurysm is also common when autosomal dominant polycystic kidney disease. So one drug which we have to remember is nimodipine. Nimodipine is important in SAH to prevent cerebral vasospasm. Epidural hemorrhage in trauma, it will be biconvex shape. Subdural hemorrhage will be concave shape. Coming to cranial nerves, important points are, if the entire half of the face is involved, it is LMN facial palsy. Example is Bell's palsy. And if you think of some brainstem syndromes, there will be crossed hemiplegia. In that Millard-Gobler syndrome or Foveli syndrome, these syndromes are LMN facial palsies. They involve the entire half of the face. Only if the lower part of the face is involved, it is UMN facial palsy, occurs in stroke, cortical or internal capsule involvement. Now about the third nerve, diabetic third nerve palsy, there will not be pupillary dilatation. Aneurysmal third nerve palsy, there will be pupillary dilatation because in aneurysm there will be compression. Pupillary fibers are peripheral. Whereas in diabetic palsy, only the core is affected, the central part of the nerve is affected, but pupilomotor fibers are peripheral, so pupillary fibers are spared. About seizures, we have two types, focal onset seizures and generalized onset seizures. Focal onset seizures, the drug of choice as per Harrison is lamotrigine or carbamazepine. For generalized onset seizure, drug of choice is lamotrigine or sodium valproate. Remember sodium valproate here. Typical or atypical absence seizure, sodium valproate. So except in focal onset seizure, sodium valproate comes everywhere. If there's a generalized tonic-clonic seizures, status epilepticus. So if there is a GTCS which is producing a status epilepticus, first we should give IV benzodiazepine like midazolam or lorazepam. If it fails, then we have to give IV anti-epileptic drug which could be phenytoin or fosphenytoin or levetiracetam or sodium valproate. Still, if it continues, we should give benzodiazepine infusion. Still, if it continues, we should give thiopentone, that is barbiturate infusion. Last step, we should go for general anesthesia. About headaches, one important type of headache is cluster headache. It lasts for 15 minutes to 3 hours. Timing is important because in migraine, the time duration is 4 hours to 3 days. In cluster headache, it is 15 minutes to 3 hours. Treatment is oxygen, sumatriptan injection. Prophylaxis by verapamil, topiramate, melatonin, and galcanezumab, which is a monoclonal antibody against calcium sensing receptor. Coming to the neurodegenerative diseases, Alzheimer's disease is a tauopathy. It progresses as memory loss followed by behavioral disturbances. This is important because if behavioral disturbance comes first, we have to think of frontotemporal dementia. Treatment for Alzheimer's is cholinesterase inhibitors, that is donepezil, rivastigmine, and memantine. They increase acetylcholine in the brain, thus helping with memory. Parkinsonism is a tetrad consisting of bradykinesia, rigidity, resting tremor, and postural instability. Parkinson's disease is one of the diseases which have Parkinsonism. It is a neurodegenerative disease where synuclein gets deposited. Parkinson's plus is an atypical Parkinsonism which has some features in addition to these four, and there is poor response to levodopa. So the types are Lewy body dementia, corticobasal degeneration. In Lewy body dementia, there will be dream delusions, etc. Corticobasal degeneration, there will be cortex. So Alzheimer's, that is memory loss plus Parkinson's. Multiple system atrophy is of two types, MSAC and MSAP, and we have PSP, progressive supranuclear palsy, where there will be eye changes, eye movement changes. So what are the MRI findings? Parkinson's disease, we have loss of swallowtail sign. Swallowtail is the normal substantia nigra. When it is less in dopamine, there will be loss of that tail. MSAC will have hot cross bun sign. MSAP will have putaminal ring hyperintensity. Progressive supranuclear palsy will have hummingbird sign. Now coming to demyelinating diseases, multiple sclerosis. Multiple sclerosis is CNS demyelination. Multiple sclerosis is a relapsing remitting disease. Optic neuritis is typical here, and if you do lumbar puncture, we have oligoclonal bands. Neuromyelitis optica or Devic disease is also CNS demyelination, but contrary to multiple sclerosis, it's single phase disease. It occurs only once. Here the classical features are optic neuritis and transverse myelitis, especially longitudinal extensive transverse myelitis. Here there is a good steroid response. In multiple sclerosis, only in few cases steroid response will be there. Here we see aquaporin in lumbar puncture. Guillain-Barré syndrome is a peripheral nervous system demyelination. Here the classical clinical picture is ascending paraparesis, usually follows a diarrheal disease, especially caused due to Tauferema vipelli. In nerve conduction study, we get demyelination pattern. What is demyelination? Myelin is needed for fast conduction in neurons. So when demyelination is there, conduction velocity gets slowed. Conduction velocity becomes slow, and we have something called as F wave latency. That is also prolonged. Actually, latency is prolonged because the impulse takes time to get propagated. So that is the finding in nerve conduction study. If you do an LP, we have cytoprotein dissociation. That is, protein will be high, but cells will be low. Lymphocytic cells will be low. Treatment here is IVIG or plasmapheresis. Now coming to the pure muscular diseases. A disease of neuromuscular junction is myasthenia gravis. It is an autoimmune disease where there are blocking antibodies against the acetylcholine receptor. Acetylcholine receptor is a postsynaptic receptor. Sometimes if acetylcholine receptor antibody is negative, usually acetylcholine receptor positivity is seen in 85% cases. In the remaining 15% cases, we may have anti-MuSK antibody positive. The classical clinical picture is fluctuating fatigable weakness. If you do a repetitive nerve stimulation or single fiber EMG, the response is decremental response because As we keep on stimulating the muscle, acetylcholine gets utilized and muscle contraction will be slowed. Treatment, initial thing is pyridostigmine, which is a cholinesterase inhibitor. So we can increase the acetylcholine in the neuromuscular junction. Steroids can be given because it's an autoimmune disease, immunosuppressants, thymectomy because many cases of myasthenia gravis are associated with thymoma. Close DD for myasthenia gravis is LEMS, Lambert-Eaton myasthenic syndrome. It is a paraneoplastic disease which occurs secondary to small cell lung cancer. Small cell lung cancer produces an antibody which is called VGCC, that is antibody against the voltage gated calcium channel of the presynaptic membrane. So myasthenia gravis is postsynaptic, LEMS is a presynaptic problem. So here there is an incremental response on repetitive nerve stimulation. Being a paraneoplastic disease, we have to remove the antibody. Treatment is plasmapheresis or IVIG. Now the next pure motor disease is a motor neuron disease. The most common motor neuron disease is amyotrophic lateral sclerosis. Here we have mixed LMN and UMN pattern. There are MNDs with pure LMN. There are MND with pure UMN. ALS is a UMN plus LMN disease. Here it is a TDP4 related disease. Here there is a deficiency of sodium oxide dismutase enzyme. So free radicals get accumulated which damages the nerve. So the treatment here is riluzole and edaravone. They are basically free radicals. So they scavenge the free radicals and prevent the nerve injury. Now next is myopathy, muscle dystrophies, creatine kinase will be elevated. It's a muscle problem. Now about meningitis, when you do CSF, if there is a lymphocytic CSF, see the protein and glucose. If there is lymphocytic CSF plus high protein and low glucose, it means there is tuberculous meningoencephalitis. TB bacteria utilize the glucose and it produces many proteins. But if there is a lymphocytic CSF with a normal protein and normal glucose, which means it is not a living organism, so glucose is not utilized, protein is not produced. It is viral meningoencephalitis. In immunocompromised patients, if there is a lymphocytic CSF, always we have to do India ink stain to look for cryptococcal meningitis.